Thanks so much for asking me to participate in this program. I've been asked to speak about initiating glaucoma therapy utilizing visual fields. These are my financial disclosures of relevance. I'm receiving an honorarium for speaking in this program, and I do have a patent with Zeiss for an OCT product. Just to put things in context, these are the three situations where I initiate glaucoma therapy in manifest glaucoma. Those would be patients who definitely have glaucoma and are not suspects. Number one, and most commonly, when a patient has optic nerve or OCT findings consistent with glaucoma, plus a visual field defect that indicates glaucoma, I will initiate therapy. Secondly, without visual field evidence, I will still initiate therapy if I can document an increase in cup to disc ratio, but this needs to be by stereo photographs, not by observer report. And thirdly, if I can document progressive thinning of the retinal nerve fiber layer beyond what we would expect by aging, we call this progression in the green, and I initiate therapy in this case. These are the characteristics of glaucomatous visual field loss. The defects are almost always localized rather than diffuse. They respect the horizontal meridian. They begin nasal to the blind spot. They're demonstrable within the central 30 degrees, but any defect has to be repeatable in the same general area. And here are some examples of these principles. This is an early glaucomatous defect which respects the horizontal meridian in an expected area of the visual field. The horizontal meridian is an incredibly important landmark for glaucoma because it reflects the horizontal raphe of the retina. And we're used to seeing these defects that end abruptly at the horizontal meridian due to the horizontal raphe and the pathophysiology of glaucoma that we don't have time to go into during this short talk. Here's another superior arcuate defect breaking into a nasal step. And the nasal step is created by this principle of the defects ending at the horizontal meridian. The defects generally begin nasal to the blind spot. Notice that this doesn't say in the nasal quadrants, but this is a Bjerrum scotoma emanating from the blind spot. And you can see that on the gray tone printout, a pretty classic Bjerrum scotoma, and that begins nasal to the blind spot. But there are perhaps fewer than 5% of cases that can have a temporal wedge defect. So you need to pay attention to the points just temporal to the blind spot. Notice that this patient also has some defects nasal to the blind spot. However, this is another patient with a temporal wedge defect seen well on the gray tone printout. I use the Hodapp-Anderson criteria for minimal abnormality in glaucoma. And the most sensitive of these, and the one that I use the most, is the first one, called point-wise criteria. I look for 3 or more adjacent points in an expected location of the central 24-degree field that have a p-value less than 5% on the pattern deviation plot, one of these having a p-value less than 1%. The glaucoma hemifield test and pattern standard deviation abnormality are less sensitive, but can add supportive information to this. Here's a patient with an early inferior Bjerrum scotoma. There are 3 points on the pattern deviation plot with a p-value less than 5%, and 2 of them with p-values less than 0.5%. Here's another very early defect, a nasal step with 5 points in a typical location of the visual field with p-values less than 5%, one of which has a p-value less than 1%. Again, with these early defects, you want to make sure you repeat the visual field to see if there's an abnormality that qualifies on a repeat visual field in generally the same area. The glaucoma hemifield test is certainly the easiest to interpret, and I do use it much of the time just to realize that this is when the instrument compares 5 areas typical for early glaucoma defects to 5 mirror image areas in the opposite hemifield. And if these are statistically significantly different beyond what's expected physiologically, because there are some physiologic difference between the superior and inferior hemifield, then the glaucoma hemifield test is either borderline or abnormal. Here's a glaucoma hemifield test that's abnormal by this inferior arcuate defect that breaks into a nasal step. Notice the PSD is still not at less than 5%, so this is a little more sensitive than PSD. And another early paracentral defect in one of those regions compared to the opposite hemifield that's statistically abnormal and shows up on the glaucoma hemifield test as such. The pattern standard deviation index with P less than 5% is the least sensitive of the three. And in my experience, when this becomes abnormal, at least one of the other two is almost always abnormal already, which is why I say it's less sensitive than them. But it's additive evidence because the PSD is an index that tells you how uneven the hill of vision is and flags localized defects. In this case, the p-value is less than 5%, but there's already an inferior arcuate defect breaking into the nasal step that would be flagged by our pointwise criteria, and the glaucoma hemifield test is outside normal limits. And then lastly, two paracentral defects, one in the superior field and one in the inferior field, that cause the PSD to be statistically significantly abnormal. Notice the glaucoma hemifield test is abnormal as well. So I've provided some criteria that might be helpful in your practice in identifying early visual field defects, and also plenty of examples that would apply to your practice. Thank you.
Thank you, Don. I'd invite the panelists to join us all back. We've just looked at the single field printout and what does it mean? When do you interpret it to be abnormal? Don, you spoke about repeatable. Murray, you spoke about reliable. And I'd just like to get some comments from the panel. When you look at a test, how do you know it's reliable? And I'm actually going to point this at Mike, because I know we've talked about this before, and I find it tough. I can find the really unreliable fields, but what tells you that a field that's so-so is reliable or not reliable?
I think that having been one of the inventors of all those reliability indices, I can take the blame that the longer I've gone in this business, the less satisfied I have been with relying solely on the reliability indices. And so I'm looking for some confirmatory finding. If I'm thinking about fixation losses, I want to quiz the perimetrist. I want to look at the gaze tracking, and only then, if those things confirm what was found in the fixation loss rate, would I consider not using a test and asking for a retest. Same thing in false positives. I want to see some other signs like white scotomas, like a reverse pattern and total deviation map where the pattern deviation is worse. Ridiculously high threshold measurements that Murray mentioned. These things need to be confirmatory. And so my message is, I advise you not to discard tests solely on the basis of the reliability indices.
Mike, can you just comment on, the people go by percentages, and you have false negatives and false positives as well as fixation losses all in the same location, and many people learn that they're all equal in terms of importance, and they go by the original numbers of 25% and 33% as being numbers and until then in which the reliability indices are fine. When we've talked about this at length, that those numbers are old and that the indices are not equal. And I was hoping maybe you could just mention, since you are the developer of those, which are there ones that are more important, and what about the percentages?
First of all, the percentages, I no longer believe in hard numbers for percentages. And I'll say it again, I would never throw out a test solely on the basis of percentages of fixation loss, false positives, or false negatives. Beyond that, back in the 80s and in the 2000s, and now again in 2019, people have identified false negatives as being much more highly correlated with how bad the field is, how damaged the field is, than with patient alertness. So you see in the see to faster strategy, we give you the option of turning off false negative checks because we don't see much value in them. If you see value in them, you can turn them back on, but we turn them off. We also have turned off fixation loss, the Hale-Krakow method, because repeated studies, and we can dig this out and send it out if people really want to see them, have suggested that there is not much relationship between Hale-Krakow fixation losses and damage to the field, changes in the field. And Anders Hale of Hale-Krakow is saying you really should do gaze tracking. And a paper 2 years ago by Ria Asaoka showed that gaze tracking indices are pretty useful. We have not seen them in any commercial device yet, but they're pretty good. So, and I can say similar things about false positive rates. So I think that trigger happy behavior is important to find. I don't think that false positive rates are very highly correlated with trigger happy damage to visual field losses. So I'm seeing, yet in retirement, I'm looking at a new career making reliability indices. And I think I need to take, and Anders and Boo will need to take another shot at this.
Yeah.
Mike, before we get off that, could you just summarize for the attendees how the Hale-Krakow method works, and then a little bit more about the gaze tracker and why we might want to be looking at that?
Yeah, back in 1972, when Anders built his perimeter for his PhD, he did not have a telescope or in video eye monitors, forget it, they didn't exist. So he couldn't see the patient's eye. So he put in the Hale-Krakow method, and Krakow was his dissertation professor, and it essentially puts a stimulus in the assumed location of the blind spot. And the idea is if the patient presses the button when you show something in their blind spot, they were not looking in the correct direction. The problem with that, of course, is patients move around and they tilt their heads and move the blind spot to a new location through head tilt, or sometimes the perimeter doesn't find the blind spot to start with.
And then the gaze tracker, which is sort of that little jaggy thing along the bottom.
So we live in the era of gaze trackers in commercial games, right? Which follow gamers around. The one in the Humphrey perimeter is one generation back, and it looks at reflections off the front of the eye and is really quite precise. But we are in the age of gaze tracking, and it's becoming increasingly reliable and able to tell you where you are looking, not only where are you, but also where you're looking, to very high precision. And with that, we've seen a paper, the Asaoka paper in 2019 that showed, a series of papers actually, showed that gaze tracking indices were a pretty good estimate of test reliability and retest variability. So I see that as the next step for gaze tracking.
So we've talked a little bit about the reliability. I'm curious, for any of the panelists, what do you do to give the patient a jump start? How do you get the patient trained so they start giving you reliable fields, maybe on the first try, maybe on the second try, and they don't have to throw away 2 or 3 fields before they start being useful? John, what are your thoughts?
We always used to say that visual fields, even automated perimetry, like we're talking about, is only as good as your technician or the person doing the field. And I still think there's an element of truth in that a lot of people are okay with visual fields. A lot of people can give you pretty good visual fields straight away. We all see that. It's a case of identifying the ones that are struggling, the people who who don't give us good fields as quickly as possible. And that's what we always hope the reliability parameters would do. And I think, you know, for the trigger happy patients, the old false positive, you used to be able to see that at the beginning of a test. As we know, we can't do that now as easily. But, you know, again, a good technician will see a patient whose eyes are wandering or give you a few false positives, and they may be the one you need to do that, you know, a trial test first, get them trained in, and only be able to rely on results a few fields in. But, you know, I don't think it's every, you know, I think it can be exaggerated how many patients struggle that way. I mean, it's a problem. We need to find them, but, you know, a lot of people can do fields as well.
Any other thoughts about how we can help our patients learn to do this better?
Rob, you know, going back years ago, in an older version of the Humphrey perimeter, they had what was called demo mode.
Mm-hmm.
And you could turn on the demo and run it for the patient, and that would run, and then you would stop it when you watched the patient, you thought they were, you know, they got the test. I mean, that's no longer available. So what I'll often do now is run them often in Cedar Standard and just run a test started. And the idea of running it at maybe 30 seconds, 45 seconds, hopefully not too long. And once they appear to understand, then I will cancel that test, delete it, and start with the test strategy that I want. But I also will run a test quickly, just especially if it's a brand new patient, so they understand.
Yeah.
Don, I want to go back to what you were talking about, because the machine helps me. It says hemifield test abnormal. But what do you find most common? Are there certain triggers for you where you say, yeah, this is usually where I see those early glaucoma patients?
Yes, I think it's important to look at the whole field. And I mean, early defects in glaucoma are pretty typical. You see paracentral defects, you see those verum or comma-shaped scotomas, you see arcuate defects, you see nasal steps. So a lot of it is looking for the pattern on the pattern deviation plot. I think Murray showed a great example of, you know, why you wouldn't look at the gray tone printout. You're just going to miss too much. That's where the action is. Although I might warn you, if the total deviation plot is completely normal and you're seeing something suspicious on the pattern deviation plot, that's a phenomenon we call pattern reversal, and you should probably ignore those on the pattern deviation plot. But in general, that plot and the patterns that it shows you are sort of, you see the same things over and over again. Now, you can't conclude that they're from glaucoma. There are things like, you know, retinal vein occlusions and other things that can cause these kind of localized defects. That's why you always have to look at the fundus. But you'll see things over and over again that make sense.
Thanks. You know, I admit my eye goes right to the grayscale. And Mike, what's your advice about the grayscale?
That's where you put your coffee cup.
Okay, thanks. We have some good questions, and I think I'm going to take one of them before we move on, and then we'll get to the others with another presentation. But Mike, you were talking about absence of a blind spot or moving a blind spot. What does it mean if the machine doesn't find a blind spot? Is that a problem?
By that you mean you don't have a black area in the grayscale?
You don't have a black area
in the grayscale. You know, that's not the end of the world. It's reassuring to see that you were able to find the physiological scotoma on this patient, because that reinforces your feeling that the patient's responding as you hope they are. And if it's present, you can say, okay, that helps. And if it's not present, you don't really know much. But often you'll find that blind spot is not where the machine thought it was, which is where the little triangle symbol sits in the raw threshold presentation. And that's another explanation for why the fixation loss numbers are high. And that's the most common explanation, much more common than poor patient fixation stability.
Thanks, Mike. We may come back to some of these topics. We've talked about detecting abnormal. Let's move on to looking for progression.